Okay, so let's get started with the third module of the second week. So in this week, if you remember the first two videos, we tried to look at different contaminants, where they are used in electronics, why they are used in electronics, what is their health impact, environmental impact. Then we also looked at some of the case studies, one from China, and then I showed you the case very quickly. We showed that China one we went into detail in terms of the data, and then we looked at quickly some of the from a photographic tour you may want to call it, in terms of the impact in Ghana as well as in Nigeria, so which was near Lagos. So just to put things in perspective, now what we will start talking about more in say we looked at these are bad, what we are calling it, these are bad, these are harmful, but how we calculate that, at what concentration they are really bad. So that is called a concept of health risk assessment. We talked about the exposure scenario as well in the previous one of the previous video in this week. So in terms of exposure scenario and the concentration level, how we do this risk assessment calculation, so how that math is done, we'll try to answer it over here. So we'll go over some of the basics of the methodology, and then we'll try to have some examples. So in terms of the risk assessment, what is we basically is trying to generate data so that we can relate response to dose as a dose response curve, which you may have seen it. It's very similar to even when you take the medicine, isn't it? You take a certain dose, and based on the dose there is a response the body gets, the response the body gives in terms of something getting better. And if you don't get better response, what doctor will do? He will change the medicine and give you some other medicine. So any dose you give, there is a response. So that's so based on similarly for the contaminants too, for the toxicants as well, that if there is a certain dose, of course the body will have certain response. So the risk management or the risk assessment and the risk management is the process of the decision making. So we have to say everything has a risk. While crossing a road has a risk as well, while driving from point A to point B has a risk, even swimming in a swimming pool is a risk, going to the beach has a risk. So everything has certain amount of risk. What we need to do is to manage that risk. We have to make the decision in a such a way so that we can allocate our natural resource, allocate the natural resource, so that we can minimize this risk. Some material may have based on their toxicity level and other stuff has higher risk versus the other. So we can so risk management, or once the risk assessment is done, then the risk has to be managed, where we have we make certain decision to how to allocate natural resource to protect the public health and the environment associated with that. So it's a 4-step process. It's let me try to move this on that side if I may. Sorry. Yeah. So we can see it. So risk assessment is a 4-step process. The first thing is we need to find out the hazard identification. So as you can see the top box over there, that's the hazard identification. Now what does that mean? We have already done that. So from the last few videos, that's what we have been trying to do. We have been trying to identify the different chemicals which are present in the electronic waste stream. So those are the hazard. And I'm talking now, I'm just kind of discussing it just from the from e-waste perspective. There are that hazard identification in a transportation sector will be defined in a slightly different way. But for the electronic waste, those contaminants, those elements that we already talked about in the last couple of videos, those are our hazard. Then we have to, and then we need to know their concentration. So that's the identification of the hazard. So that part we kind of already looked at. Now the next step will be like at what level it is becoming available to the public, or at what level we are getting exposed to. That you saw in that, if you remember from the China case study, which we talked about the different levels are present in PM 2.5, different elements. So those are, we had a base in other city which was very far from the e-waste processing facility, and then we have a small, we had two sample set. One was near the e-waste processing facility, one was away from e-waste processing facility, and we compared the numbers. So that's And the exposure we already talked about: inhalation, dermal, and ingestion. So that's your exposure, that's how it will get exposed. Then we need to do the dose response assessment, how that particular dose is, what kind of effect we get. For that we do EC50, LC50, IC50, those kind of calculation, and based on hazard, then exposure, as well as the dose, based on these three aspects, we do risk characterization. We try to identify what is the real risk. Is the risk is there? Something may be very toxic, but if it is not, we are not exposed to it. Say if you have a cyanide in a small bottle kept somewhere in a lab in a corner, I am not going to touch that. So, I am not getting exposed to it. So, unless I get exposed, then only there is a risk. If I am not exposed to it, there is no risk. That's a hazardous material, that's a hazardous chemical just sitting there, but I'm not touching it. It's not getting into my body either through my nose or through my food or through my skin. So if it's not, our risk is not there. So that's what we need to look at: the exposure assessment, and then exposure, based on the exposure, what is the dose response, and then based on that we can characterize what is the risk. And once we know the risk, we have to manage that risk. Even when you talked about those of you who have, I am pretty sure that all of you must have taken a water course. So when we talk about this water quality standard, when you have 10 microgram per liter of arsenic as a drinking water standard, that also has a 1 in a million cancer risk. So out of a million people, we are taking that, okay, out of a million people, let's take that one person will still have cancer at the level of 10 micrograms per liter. Ideally, we should try to bring it as close to zero as possible. But as you go to closer to zero, you need more advanced technologies, more that means more cost. So at some point of time, you need to manage that risk, because you may have to see how to better use your resources, the economic resources that the country has. So it's a 4-step process: again, risk assessment, hazard identification, exposure scenario, dose response, risk characterization, and finally we have to manage that risk. So that's the risk management part. So in terms, look at some of this basic definition. Hazard identification is where you have to process of determining whether or not a particular chemical is, so you are looking at whether or not a particular chemical is causally linked to particular health effects. We already talked about that. Dose response is you try to characterize the relationship between dose of an agent and received and incidence of adverse health effect. That you do mostly in the lab setting. In the lab setting, you feed these chemicals to guinea pig, mice, and other species, and you start seeing their impact. And that's how you get those data, and in terms of the dose response curves. So that is done for that aspect. Then you do the exposure assessment, which involves determining the size and nature of population which is exposed. You look at the size of the population, you look at the nature of the population, and then you try to find out as well as the length of time and the toxicant concentration. So that's basically what kind of exposure they are getting. And based on these integration of above 3 steps, we try to find out what is the actual risk, what is the risk, and then we try to characterize that risk from there. So hazard identification is the first step, whether the exposure of a particular chemical likely to have an adverse effect or not. And toxicant will primarily enter the body in 3 different pathways: inhalation, ingestion, and dermal contact. Then you generate the information through testing on microorganisms and animals by acute or chronic carcinogenic chronic bioassays. So that's what you try to find out their hazard. Then acute toxicity, chronic toxicity, you can go for LD50. Acute toxicity is a short period, chronic is a long period. So that's you refer to chemicals of a long term exposure. LD50 is which kills 50% of the population. So is the dose at which kill 50% of the population. So we did all those, we have to do all those kind of calculation based on the data that we collect using those toxicity testing on different animals, different species. So for short term carcinogens, assay is we try to look at the specific procedures, specific organs of mice or rats are subjected to known mutagens to find out whether the tumor will develop. Chronic is mostly costly, complex, long lasting test, involves hundreds and thousands of animals over a long period of time. So both things are looked at. Minimum test requirement, they say even when you do these kind of testing, when you try to come up with this dose response, you have to do a statistically relevant data sets. So, there is a national toxicology program in the US. They have established the following minimum requirement for a acceptable chronic bioassay. So, you need to test at least 2 species of rodents, at least 50 male and 50 female species has to be tested, at least 2 doses must be administered with no dose control. So, that is you have, this is the bare minimum that you need to do. Then on human studies, data obtained from animal studies or method is difficult to interpret for humans. So, some substance may can cause tumor to rat, but may not cause to human. So, what by attempting to find correlation between disease rate, environmental factors, a quantitative relationship between exposure and risk can be developed. So, we try to do some like a model, some extrapolation, a statistical model to come up with that. So, in terms of if you look at the parameter for determining exposure and disease, say if you have exposed, you had exposed and not exposed, with disease and without disease. So, exposed and with disease is A, without disease is B, and that not exposed C and D. So, the attributable risk is the difference between the odds of having disease with the exposure and odds of having disease without exposure. So, it is exposed and having the disease is A, not exposed, but it still have the disease of B. So, that if you look at relative risk, so relative risk becomes what? A divided by A plus B is what with disease you are exposed. So, that is your where you are supposed to get it. So, that is the attributable difference, and then C is when the C numbers were not exposed, but it still got the disease. So, it is a C divided by C plus D. So, that is the fraction kind of gives you the value where you can get the disease even without being exposed to that. So, we look at that is a relative risk, we define that as a relative risk. Then odds ratio is where you have A times D divided by B times C, where you have the with disease, you have exposed with disease, not exposed without disease. So, that is kind of that's what you expect, isn't it? You are exposed, it should get the disease, not exposed should not get the disease. So, that is again it is similar to relative risk. So, number 1, if its number is above 1, it will suggest that there is a relationship between exposure and risk, and B and C not exposed and getting the disease, exposed not getting exposed, but does not get disease. So, that is the B and C. So, that is A multiplied by D divided by B multiplied by C. So, that gives us the odds ratio, and if it is greater than 1, it gives us some indication that yes, exposure and risk is related. Attributable risk is where you have A divided by A plus B, where you get the disease because again A with exposure, and minus C divided by C plus D because you are getting the disease even without being exposed. So, that is your attributable risk. Attributable risk is the difference between the odds of having the disease with the exposure and odds of having disease without exposure. So, these are the different terminology used in terms of the risk assessment when we are trying to find the exposure and disease different parameters that we use. And then there is the epidemiological data analysis. Epidemiological data is when you have a population which got exposed to certain contaminants and then got sick. So, the data collected from them, it is not the rat and mice data, it is just it is the data on the humans. So, epidemiology is a huge area. There are certain departments of epidemiology as a part of College of Public Health. So, there is a huge area of research and teaching and all that. Unfortunately, we do not see that much popular in Indian context. In fact, the whole public health education, unfortunately, after our independence, this public health became part of it went to the doctors, and it is not really a doctor, it is kind of between the doctors and the engineers. So, that is a environmental engineer and the medical doctor, something in between will be the public health professional, environmental health professional, and its environmental health is one aspect of public health. Public health is a huge program, and it needs to be developed. Actually it's a good bridging point between engineers and medicine field, where we start looking at the interaction, because ultimately what is the goal? Goal is to better human, our humans should be more productive, there should be less sickness, people should be, we need to be proactive in terms of the preventing the health, because that is the proactiveness of health prevention is what is public health. But unfortunately, since now it is a reactive, our health sector is becoming reactive rather than proactive, and that proactive comes in the public health aspect. So, let us look at this epidemiological data study. So, in evaluation of this personal records of an employees of a plant, the plant is manufacturing vinyl chloride, 200 workers, 50 developed cancer, so and liver cancer. I am sorry, the R is missing here. A control group consisting of individual with a smoking history similar to the exposed workers and who are unlikely to encounter vinyl chloride had 24 with live cancer and 450 who did not develop liver cancer. So, find out the relative risk, attributable risk and odd ratio for those data. So, again what we the previous slide, we can set up the table here as well. So, let us look at the 2 by 2 matrix. So, we have with disease, without disease. So, some people got exposed to vinyl chloride and we had 15 people which got liver cancer, and then other we had 24 people which were here we had never encountered vinyl chloride, but had 24 with the liver cancer and 450 who did not develop liver cancer. So, we had 450 who were not exposed, did not develop liver cancer. Here they are exposed, but 15 people got liver cancer and 185 did not get liver cancer. So, again remembering the previous slide, the 2 slides before, relative risk, we can divide. This is now A, what we have A, B, C and D. So, we had what A divided by, so this plus this. So, that is the relative risk in terms of exposed and disease divided by not exposed getting disease. So, it is more than 1. Odds ratio is 1.52, so which is 15 times 450 this times this. Attributable risk is 15 times 200 minus 24, so you get 0.024. So, that is the risk in terms of where if you are exposed you will get more chances of getting it. So, that is multiplied by 2.4% or something like that. So, that is kind of how we do some of these data analysis in terms of what whether the risk is there or risk is not there. So, this kind of calculations are useful in terms of finding out like a human health risk assessment part of that. Then in terms of the carcinogens, when we look at there are evidence from clinical study, epidemiological evidence, there are different groups, group A, group B, C and D and E. A is a human carcinogen, B1 and B2 probable human carcinogen, C is possible human carcinogen based on its we do not know for sure. B is A is sure shot that it is a human carcinogen, there has been enough data to prove that. B, lab data kind of shows that yes, it could be human carcinogen, but we are, and there are some anecdotal evidence from epidemiological data as well, but we are not really 100% sure as such. Possible human carcinogen is based on the rat and mice study. We see that yes, there are some indication that yes, it could be human carcinogen, but we have not reached the surety stage yet. We do not have epidemiological and other data to support that. Group D is not classified, group E is evidence of non-carcinogenicity. So, it is not we do not, it is not carcinogen. So, these are the classification that you see. And weight or evidence categories for human carcinogenicity. So, we look at human evidence, if you have sufficient this limited evidence is there, inadequate. So, sufficient, so of course, limited evidence, inadequate evidence, no data, no evidence. So, based on that, as you can see, so animal evidence and human evidence. So, in this shows like a where you have human evidence as well as the animal evidence. This is limited. So, if it is limited, it is not sufficient, it is kind of inadequate, no data, no evidence. So, based on weight of evidence category for human carcinogenicity, based on the lab data, we can try to look at the human evidence and try to correlate which one kind of works out where. So, based on all these data, we try to generate this dose response curve. The dose response curve is you do a certain exposure, and for exposure you look at what is the corresponding impact. So, for substance that induce a carcinogen response, assume that exposure of any kind will create some likelihood of cancer. For non-carcinogen, we assume that there is some threshold dose below which there will be no response. 2 major doses proposed, like one hit model and multistage model. So, one hit model is the relationship between the dose and the lifetime risk probability. We can put it in this kind of equation where your like a dose and that and the lifetime probability of cancer, which is PD, can be expressed as 1 minus e to the power of minus q0 plus q1 times t. Now, what is this q0? Q0 and q1, the parameters picked to fit the data. And so, when d is equal to 0, result will be expressed as the background rate of cancer. So, if there is no dose, so there is no dose. So, this the data that we will get, that is the background, that is the background data. So, now as you increase d values, as the dose goes up, you will see your probability also will keep on changing. So, additional risk of cancer above background, which is AD, is PD minus P0. PD is this value for any particular, just to explain that, just to get you very clear, PD is this is the dose. Q1 and Q2 are the parameters picked to fit the data. So, they are basically constant. So, now as you increase the d value, you will see that changes in the probability. Now, at d is equal to 0, that means no additional dose, that is the background probability for having that particular cancer. Now, as we increase the d, the numbers will change. So, to find out the additional risk of the cancer above the background was when P0, when d is equal to 0. So, that's we are calling it P0. Now, when d has a certain value, we are calling it PD. So, PD minus P0 is giving us what is the additional risk. So, value of AD is approximately equal to Q and D for small doses. At small doses, this is actually equal to probably closer to Q1 times D. So, that's so that's the one hit model. Now, the multi-stage model is where you take the dose and the lifetime risk probability of cancer PD is divided by 1 e to the power of minus Q0, Q1 times D, Q1 times D square, and then the list goes on. So, this is the EPA choice is multi-stage model. They go for this multi-stage model in terms of getting the probability. It is a linear at low doses. If you have a low dose, it is linear with constant proportionality picked in a way that the probability of overestimating the risk is 95%. So, you always try to overestimate rather than underestimate. So, here you can again d is equal to 0 will give you background, and then when as the d changes, you will have that PD giving you the what is the probability of that cancer. So, this is called multi-stage model. Now, we can calculate the potency factor for carcinogen. So, resulting dose response curve has the incremental risk of cancer above the background data on the y axis, and the lifetime cancer toxicant along the x axis. At low doses, the dose response curve is assumed to be linear, but the slope of the dose response curve is called the potency factor or the slope factor. That is some people call it a slope factor, some people call potency factor. So, that is the slope of slope. So, this is potency factor is the incremental lifetime cancer risk divided by chronic daily intake. So, that is how we define potency factor. Whatever is the lifetime cancer risk divided by the daily intake, which is a milligram per kilogram per day, and so that is the denominator is the dose averaged over the entire lifetime. It has units of average milligram of toxicant absorbed per kilogram of body weight per day. So, that is the denominator, and so that is how we calculate potency factor or the slope factor. Now, since risk has no unit, the units of potency factor as milligram per kilogram per day as a inverse of that. Now, we can rearrange that equation and then we can find out the incremental lifetime cancer risk. So, if you put that incremental, if you from the previous one, if you go back to the previous slide, you can see potency factor is incremental lifetime cancer risk divided by the chronic daily intake. So, this we can call it CDI, this is a potential factor. So, if you want to find out this value over here, if you are interested in this thing over here, just a minute, let me grab that. So, if you are interested in incremental lifetime cancer risk, which is being tried to do in the next slide, and let us get rid of that over here. So, in terms of incremental lifetime cancer risk, which you see over here. So, that is what it is CDI, which was chronic daily intake times the potency factor. So, we just rearrange that equation. Now, potency factor is there. Potency factor or the slope factor is available in the integrated risk information system. So, IRIS database, the EPA database has that potency factor. So, we can get the data from there. So, now incremental lifetime cancer risk is CDI, which is the chronic daily intake. So, we can find this particular value. Once we know the potency factor, so we can calculate what is the incremental lifetime cancer risk. And as I said, potency factor or the slope factor as we want to call it is available in the EPA database, IRIS database for most of the contaminants, most of the chemicals. Okay, so being said that, if we can calculate, generally CDI can be found out by the equation given below. We can calculate this CDI, which is the what we call was that chronic daily intake, and what that would be, you can take the average daily dose. So, average daily dose, how much milligram per day, and then the body weight. So, that's kind of gives you milligram per kilogram per day. So, that's CDI values. Now, if the contaminant is in drinking water, then CDI can be expressed like a concentration in milligrams per liter times intake rate, how much liters per day. So, if you say, so you have a certain contaminant x milligram per liter, typically people consume 2 liters of water per day. So, intake rate is around 2 liters per day, exposure is how much days per life, then you divided it by body weight in kg, average body weight, 70 years say the typical life, 365 days per year. So, that if the exposure route, that can be written up for the ingestion route. For the ingestion route, this is how the equations can be written up. If it is an inhalation route, again you have milligram per cubic meter, and how much cubic meter of air we take per day in our body, exposure days per life, body weight, years of life, how many days per year. So, express both the ingestion as well as the inhalation route. So, just to give you some example, there will be some math problem associated with that in your exam as well. So, make sure that you understand this concept. If you watch the video again and again if you need to, but make sure you understand it. If you don't have, if you don't understand, let us know. We will be happy to answer questions for you, but do let us, if you need help, feel free to send us a question on the discussion forum. We'll be more than happy. So, and then so now we need to know the concentration, isn't it? It says that what is the concentration in there. So, we need to know the concentration values. So, how we get the concentration values? There are different ways of determining, generally determined through air sampling using air sampler for the air. For the water, we can do direct observation, we can measurement of pollutants, for how much potentially it may leach out. There are different leaching tests can be done. TCLP is one test which is done, which those of you who have taken solid waste class before, we have talked about there in TCLP. If you have taken solid waste class from anywhere, you may have talked about TCLP as well. So, it is one of the, it is basically to find out how much contaminant will leach in a MSW landfill scenario. So, that is on that part. But if you are in the body, we also have, we can use the test of simulating gastric acid of the body. So, our gastric acid of the body could be simulated, and we can try to find out if things gets ingested into the body, how much it will be absorbed. So, there are different ways of doing that. We will talk about, I think we can talk about this TCLP in the next class, because it is a little bit longer in the next video. It is a little bit of longer discussion on that. So, what we have done in this particular video, again in each video I am trying to say that what we are going to learn, and then towards the end I am trying to summarize what we have learned, so that you can relate to it, and you that is how what was the learning objective and what was actually what we achieved. So, in this particular video, the thing was we were more concerned looking at the risk assessment and risk management. So, I tried to give you some example. First of all, we looked at into what are the different components of risk assessment: hazard identification, dose response, exposure scenario, risk characterization, and then the risk management. Now, in terms of the risk, we also looked at different this is carcinogen, non-carcinogen, how we calculate these hazard, so like a slope factor or potency factor, and chronic daily intake rate, how those numbers are got. So, we kind of talked about that. And as part of the process of those calculation, now we are at the stage where we need to know the concentration of these chemicals getting, say in this case, getting from electronic waste into the soil or into the water. So, how we do that calculation, we will continue that in the next video. So, again look at the videos, look at the reading material, any question, put it on the discussion board, we will be more than happy to answer. And if I hope that you keep enjoying this course. We have finished now the third video of the second week, and the 4 will again I will see you in the next video. Thank you.